UK co-lead for the Trigger trial, and will be chairing this this evening, which is running along with Matt Gardner and the rest of the panelists here. It should be an exciting evening. I believe this is the first hand surgery ICOPLAST webinar that's been run, and it's a bit of an experiment really between three organisations, between ICOPLAST, who've kindly provided the Zoom platform, the ICOPLAST EU trainees, I believe, have been instrumental in getting a lot of units around Europe on board with the Trigger survey so far, and the RSTN, who provide advice on setting up and managing a network. We hope that people find it engaging, useful, and a good forum for discussion, but please bear with us. As you'll see, there's one or two teething problems, and I'll put my hand up as the first to experience those. So we've got a bit of a programme, and I'm sure most of you have seen that. I've got a slide here that I just need to get up to share, I hope. There we go. So hopefully the programme should be showing there for you all. We've got a panel. We've got a group of panelists, as you'll see. Matt Gardner, one of the co-founders, along with Professor Abby Jane, as I'll come on to shortly, of the RSTN. Matt's a hand fellow down in Oxford, along with Jeremy next to him, who is carrying out his postdoctoral fellowship down in Oxford with Matt there. Anita is a trainee over in Holland, and she has been key to really as you'll find out later, but the Trigger trial was her brainchild really, and then sought Matt's advice through the RSTN with how to get other people on board and build it into what is an international survey. Emmy is a consultant plastic surgeon, again in the Netherlands, and she's going to be giving us a talk shortly. And I believe Professor Davies, we're hoping that he's going to join us, but as yet I think isn't with us. And then Professor Abby Jane, you may well have heard of, is again a co-founder of the RSTN, and he's an associate professor of plastic reconstructive and hand surgery at the University of Oxford and Imperial College London. So without further ado, we'll go on to the programme. We want this to be an interactive evening and to make the most of the use for everyone, really, for all of it, from an educational point of view, and also to get your thoughts and ideas on the Trigger trial ultimately. So there is some webinar etiquette. You should see on your screen an option for a question and answer function, which will, those questions you can ask to the panelists, and they'll come through either to voice them or for a text response. You can also raise your hand, and we will then invite you to speak. Now, what we're going to try and do is during the talks is just let the talks flow, and then have an opportunity for discussion at the end of those. And then if you could comment on this, I mean, as I said, this is the first one that we've run, and it'd be great to get some feedback from you guys as to how it's gone and what we may be able to do in the future with this. So, without further ado, I'd like to introduce Emmy, who is going to give us a talk on trigger fingers and how do you treat them. So, Emmy.
Thank you so much for introducing me, and thank you to let me have this talk about trigger fingers. I'll first open my talk. Trigger fingers, how to treat them. Everybody who's a doctor, whether you're a general surgeon or a plastic surgeon or a general practitioner, we're all going to see the trigger fingers, and we're all going to treat them. And as I've worked in several hospitals, I think around 11 or 12 as a resident or a general surgery and plastic surgery, I've seen a lot of different protocols. And it really is the detail that makes the product. So it's it's the tiny little things to think of, and to always ask yourself the question, am I doing right? Can I do it different? Can I make it better for the patient? And I think with trigger fingers, it's not that complicated, but there's a lot of tiny little things that you can change in the treatment. If we go back to the trigger finger, I think you all know what a trigger finger is. Here you can see the pulleys, the different pulley, the system of the finger. And a trigger finger is actually a locking of the pulley, the tendon, against the A1 pulley. And as you can see in the slide, you see the nodule of Notta, who described it once. You can feel a tenderness and pain just proximal of the A1 pulley. So if you see a patient on your outpatient clinic, most of the time they tell you about a painful nodule in the palm of the hand and a clicking of the finger in the PIP joint. What is linked with it is diabetes, rheumatoid arthritis, women, and digit 4. Then the classification of Green, it's written grade 1 until 4, from pain, palm pain, to catching, locking of the digits, passively correctable, and stage 4 is fixed, a locked digit. And grade 4 is the one we need to operate on, and the other ones we could treat conservative. If you look at the different treatments described and the different treatments, the different protocols, you can see that you can treat it with a splint, or either an injection with corticosteroids, or a surgical treatment. And what I've learned in all these different hospitals is that you start with an injection, and sometimes patients come into your outpatient clinic and they've already had a few injections, or either they've been operated on different fingers and they choose to have an operation. And as I learned from different hand surgeons, I learned different ways to inject the corticosteroid. What's written in green, that's how I learned it, to put a syringe in 45 degrees into the palm of the hand, placed near the A1 pulley, the MCP joint, and as you go through the skin, you wiggle the finger and you see the syringe wiggling as well, and then you know that you're in the tendon and you need to pull it back a little bit. And if you feel resistance, then don't put the corticosteroid in, because you're going to put it into the tendon, and then you've got a chance of rupture of the tendon. So that's how I learned. But then in the many years I've worked, I've seen a lot of different ways to put the corticosteroid in the 90 degrees, dorsally from the tendon, volarly from the tendon, even just proximal to the PIP joint. And while I was injecting, and we always injected the A10 corticosteroid, we were not allowed to use the A40, because the A40 is, they were telling me, has got a higher risk of rupture of the tendon. So we always use the A10, 1 cc with 1 cc lidocaine. But it never worked that well in my hands. So I tried to make it myself better. I tried all these different ways to inject. But then I always saw them back, and most of the times, one time injection or twice an injection, and then if it fails, if it stays the same, you start operating, so divide the pulley. And as a young resident, it's one of the first operations that you can do alone, that you're allowed to do alone. And it's not that difficult, but it can be difficult. And you've got major problems. If you got an infection, you can hurt the nerve. So it's not that easy. You should know exactly the anatomy of the finger. And here you can see the anatomy. You can choose to do the incision in the skin transverse or a Brunner-like incision. If you know the anatomy, then you know longitudinally you have to cut the A1 pulley. The the second pulley is right distally from the A1 pulley. So you need to know if you're going too far, you've got a risk of bowstringing. And the nerves are really close by. They are longitudinally, ulnarly, and radially from the tendon. Here you can see the bowstringing is one of the possible complications of an operation, that you hurt a A2 pulley as well. And then you can see the bowstringing. And the infection, I think it's underestimated what the risk is and the adverse effects of an infection after a release of the A1 pulley. I think this is a major complication. So it's not a complex operation, but if you've got a complication, the patient's got a big problem. The thumb is a different anatomy from the rest of the finger, so you have to keep in mind that you've got the A1 pulley. So if you're opening the skin, you see the A1 pulley, and then you've got the oblique pulley. You always need to cut the A1 pulley radially from the pulley, so not ulnarly. Then you've got a chance to cut the oblique pulley as well. And then if you hyperextend your MCP joint, the nerves, which are really close by the pulley, they're under traction, and it's easily to hurt the nerves as well. And furthermore, with the thumb, we all know that the nerve is crossing. So if you go proximally, you want to divide it proximally, you need to see the digital nerves, otherwise you'll cut them as well. Then speaking about the thumb, if you're treating trigger fingers and you see trigger fingers in your outpatient clinic, I'm sure you will see children as well, trigger fingers and trigger thumbs. And that's a different story, a different treatment. And I think if you see a child, you need to know the anatomy and the way to treat them. So don't hesitate to send them to a pediatric hand surgeon. If you see a child with congenital trigger thumb, most of the times they're about 2 years old, because when they're young, they keep the thumb in the hand. And most of the times they come with a story of trauma, that they had some kind of trauma, the thumb between the door, but actually it has always been like this. And you need to see if it's not a clasped thumb. They keep it like this, it's in the MCP joint. If it's not a hypoplastic thumb, and you've got two different thumbs. You can treat it with a splint. If it's redressable, you can treat it with a splint. And if you can't redress it, you can operate it. And then the trigger finger in children, it's also different than the trigger thumb. The trigger finger in children, you always have to keep in mind that there might be a metabolic disorder. So the advice is to send these children to the pediatric. And if you're operating them, you need to keep in mind that there might be a different anatomy, which is responsible for the triggering. Then the trigger trial, it all started with these Skinner cords, these A40. I was never allowed to use the A40 because of the rupture of the tendon. And then I always used the A10, and I just told you that my results weren't that good. And then I started in Den Bosch, where Anita worked as well. And they used the A40. And I told them, no, you can't use it because you're going to rupture the tendon. They learned me that I wasn't allowed to use it. But then I started using it, and now I don't see the patients back anymore. So after 8 weeks, they're all good. They're pain-free. And I worked on it for 2 years. And the results are amazing. So we came to the idea to look at it. What's the difference? And I think there is a big difference between the A10 and the A40. And I'm really curious about the results after this trigger trial. And hopefully we could all treat the patients with this canine cord, A40 or A10, but with good results. So Anita, hopefully we're gonna hear from you the trigger trial, and hopefully everybody will join. Thank you so much for the time to talk about the triggers.
Brilliant. Thank you very much indeed, Emmy. I think covered what seems to be a fairly narrow, sort of not many options, but as you've shown, even with such a fairly simple thing, there are several options available for this. And I think it'll spark some discussion, which we'll probably bring on to a bit later. I think what we're going to do now is go ahead to look at some of the evidence behind treatment of trigger fingers. Jeremy Rodriguez was involved in writing the best guidelines for the British Society of Surgery of the Hand, and unfortunately he's not able to make it tonight with us, but he has put together a video sort of summarising the evidence in trigger. So we're going to watch the video now of Jeremy telling us about the evidence.
Yeah.
Just try and get some sound. It worked the other night when we had it, so.
Apologies, we'll try that again with some sound.
Are searched. A selection strategy is then applied to identify relevant studies, data is extracted from them, and their methodological quality is appraised. In the case of trigger, a clinical guideline is related closely to the systematic review of the evidence base. The British Society for Surgery of the Hand, or BSSH, publishes clinical guidelines under the umbrella of BSSH Evidence for Surgical Treatment, or BEST. The process for making these guidelines was recently updated to achieve accreditation by NICE in the UK. The first guideline produced covered trigger finger and involved the conduction of a systematic review, which has separately been published in the European Journal of Hand Surgery. In addition to the systematic review conducted as part of the development of the BSSH clinical guideline, which was published by AMEAFES, there has been a separate systematic review with meta-analysis, which was published by Wang and colleagues in Clinical Orthopedics and Related Research in 2013. And both of those can be considered here to inform our design of the trigger trial. Both the BEST systematic review by AMEAFES and the other meta-analysis by Wang and colleagues demonstrated that there have been some RCTs and quasi-randomized studies in trigger finger management. The BEST systematic review subgroup studies into those regarding non-operative treatment and those regarding operative treatment. In terms of injections, there is evidence that combining steroid with local anesthetic in an injection is more effective than injecting local anesthetic alone to treat trigger fingers, and this was demonstrated in 2 separate RCTs included in both reviews. However, there were no studies comparing different types or strengths of steroids in the injections. In terms of operative treatment, there were trials that compared percutaneous surgical release to open surgical release, and there were trials that compared percutaneous surgical release to steroid injection, as well as one 3-arm study comparing open release, percutaneous release, and a steroid injection. The inclusion of studies differed between the BSSH review by AMIFES and the meta-analysis by Wang, as the AMIFES group excluded some studies that were at high risk of bias. These were included in Wang's meta-analysis. When these studies are summarized together, there is evidence that suggests that percutaneous surgical release has similar effectiveness and risk of complications as open release, yet may be associated with higher levels of patient satisfaction. Wang performed meta-analysis comparing percutaneous release with steroid injection, and was able to do this because there have been several trials that compared these two either as 2 arms or as 2 of the 3-arm trial. In contrast, there was only one trial that involved both open release and steroid injection, which was the 3-arm trial. Percutaneous release was superior to steroid injection in terms of treatment success and patient satisfaction. There was no difference between the treatments in terms of complication rate. However, it must be borne in mind at this stage that there's still limited evidence comparing open release with steroid injection and between the variations of steroid injection, be that the type and strength of steroid used, the position at which the steroid is deposited within the finger, and the number of injections used, whether this is a single injection or a series of injections. In terms of the risks of bias, the trials that were excluded from the BSSH review by AMIFES were excluded due to issues around allocation concealment, outcome measurement, and differences between the groups after randomization.
So what this demonstrates is that there are some randomized controlled trials around the management of trigger fingers, but 2 of the most common treatments used, open surgical release and steroid injection, have had very limited direct comparison. And though there have been some concerns about risk of bias in some of the studies conducted. Overall, studies have been relatively small.
As well as the risks of bias due to trial methodology concerns, there were also limitations across the RCTs included so far. In particular, the follow-up periods were often short, usually under 6 months. There are also gaps in the evidence base around the management of trigger finger. In particular, there's a real paucity of evidence comparing open surgical release with steroid injection. Furthermore, there are gaps in the evidence around non-operative treatment interventions. There were no trials that compared treatment strategies such as splinting to injection or surgery, and there was limited evidence around the role of serial injections as a treatment strategy rather than just a single injection. Conventional surgical teaching suggests that surgical release of trigger fingers should be avoided in patients with rheumatoid arthritis for fear of aggravating ulnar deviation at the MCP joint. But there was no evidence in the trials to explore this further. There was also no evidence to discuss whether diabetics need different treatment strategies from non-diabetic patients. And these are both areas that may need further exploration in future research.
At this point, the 2 reviews diverged. Wang's work as a systematic review and meta-analysis is complete at this stage. The BSSH work informed the development of a clinical guideline, and so the systematic review findings were then discussed in a committee that comprised all relevant stakeholders, patients, general practitioners, rheumatologists, and some recommendations were formulated
based on what information was available. In addition to this, recommendations about future research were also made, and we can consider how these might apply to the design of a trigger trial. The research recommendations that were included in the BSSH BEST guideline included that there is a need for better evidence for the management of trigger fingers, highlighting the evidence gaps that we've discussed here. In particular, studies of surgery and probably open surgery against steroid injection is needed, with longer term follow-up than just a few months. The roles of multi-injection treatment strategies need to be further explored, and whether special circumstances exist for patients with rheumatoid arthritis or diabetes needs further exploration as well. At present, there is no trial evidence to demonstrate whether other non-operative treatments such as splinting are effective in isolation or as adjuncts to other treatments. While any one study may not be able to answer all of these questions and complete this entire evidence network, a large multi-center RCT around the management of trigger finger has the potential to greatly improve the evidence base for the treatment of this very common hand condition. And I hope that you will enjoy the rest of the webinar that will discuss what progress has been made on this so far. Thanks very much.
Great. Thanks very much. Well, obviously in Jeremy's absence, but I think that was a very nice, succinct summary, really, of the evidence surrounding trigger. We do have one question that's come through, actually. So it's actually about the management of triggers and a contraindication for steroid injection from Jan de Beige, asking, do we think continued vitamin K antagonists with an INR of 2, for example, is a contraindication for steroid injection? I wonder if we just put that to one of the panelists. Emmy, I don't know, given that you've talked about your management, can you comment on that at all?
I can comment on that, Jan. Nice that you asked this question. No, for me, it's not a contraindication to use a steroid injection with an INR, for instance,
Yeah, I think, I mean, personally, in my experience, I'd agree with that. I don't know if any of the other panelists have got anything to add to that.
Actually, the question also is, do you stop anticoagulants for surgery? And for instance, do you use tourniquet or not? That would be a nice follow-up question maybe to the panel.
Yeah, I mean, I don't know, Prof Davies, I think you're there with us. What do you think about that? Can you add to comment on that at all?
Can you hear me?
Yes.
Yes, loud and clear.
Okay. I think orthopedic surgeons, and I'm one of them, playing around with warfarin is far more dangerous than doing an operation with an INR of less than 3.5. And so I just keep anticoagulation going as long as you know it's not totally wayward. And I use a tourniquet. I've tried without, I'm quite happy with that, but we train where we are, and I think to get people trained up, it's useful that they can see what they're doing and see the anatomy of where the A1 pulley starts and ends clearly, so they don't release far too much. So tourniquet, almost invariably.
I agree, Tim. So I will operate up to an INR of 3, and I'll use a tourniquet. It's very rarely that I see patients with INRs over 3 on purpose. Most of the time they're meant to be running around 2.5. So I think I would operate without a problem on most hand surgery up to an INR of 3, and I always use a tourniquet.
I do too. And I use local with adrenaline, which also helps in a relative tourniquet.
What does anyone think about the new new anticoagulants such as rivaroxaban and apixaban and the like? Anyone stop those? Or do we continue them? Continue them all?
I think for trigger finger, which I think is relatively straightforward. I continue all of them. They do bleed a little bit longer, so I press a little bit harder afterwards. I explain to the patient that they may notice a bit of blood in the dressing, but I've not had a problem up until now.
Excellent. So I think that's it on the questions at the moment. Obviously, if you guys have got any more questions, put them in through the Q&A and we'll try and bring them up. We'll move on now to Matt, who's going to talk on collaboratives, research collaboratives, and the UK experience from his position as I said, one of the co-founders of the RSTN. So over to you, Matt.
Hopefully you can now hear me and not my son who's screaming in the background. So I'm going to briefly talk about Power of the Research Collaboratives with particular reference to the Reconstructive Surgery Trials Network. So plastic surgery evidence, hand surgery evidence is often relatively poor. I like to think of it as a ramshackled shed in terms of quality. If one looks at the evidence base, there have been relatively few randomized controlled trials. I think I'm going to just stop the share. And my PowerPoint, I think, is not formatted correctly. 1 second. Apologies. Okay, that should be better, I think. So there have been relatively few randomized controlled trials within plastic surgery and hand surgery over the last 10, 15 years. As you can see here, 53 in Europe, thereabouts, and 30 in the UK. So the majority of these are actually relatively poorly designed. Most of them are single center. Only 56 of the total were multi-center. And that's actually very few for each year. And few of them are high impact, which may reflect their underlying methodology. So often research is done, but even if the methodology is slightly bigger, it's still single center and is still really a shed, even though a well-appointed shed. And I think one of the things underlying trying to build networks is trying to move from building a shed to building some really quite impressive soaring buildings, whether that be the Shard in London or a cathedral or equivalent. And really people can become a small part of something much, much bigger and more impressive. The research collaboratives in the UK developed about 10 years ago in the West Midlands, which is halfway up the UK. And this was the West Midlands Research Collaborative. And out of that, the Royal College of Surgeons in England developed the Clinical Trials Initiative. And now, as you can see, each of these logos represents a research collaborative. Some are trainee-led, some are across all levels, trainees and also consultants. And the RSTN is one of those. We have a website if you're interested to find out more, and a quick plug for our Surgical Trials Day that we run in June, and that will be in Edinburgh. So here is really a place for those within our network to find out about the projects that are going on, find out about the scientific meetings we're holding, and also some information about how to set up and run trials. Now, it's quite a daunting prospect trying to set up and actually deliver a surgical trial. And if one takes the analogy of wandering through the meadows, but with the aim of getting to the summit, then it's quite a journey. And I'm going to just go through a few things along that journey where the networks can really help. And one of the things is trying to build consensus and getting a wide range of views from colleagues, perhaps both nationally and internationally, as to how one might develop a trial idea, set the priorities in terms of research, engage patients from a broad spectrum of countries and health backgrounds, so that it's a generalizable trial that has got wide engagement. In the UK in particular, we're thinking about trying to challenge surgical dogma and perhaps look at some of the treatments that we provide with relatively poor evidence to support them. And I mentioned PICO format here just because in our discussion later, we're going to use the PICO format to think about the trigger trial. And that's a good way of framing a research question. I'll come to that in a second. So for the RSTN, our first study was looking at whether or not you should replace or discard nail beds after nail bed repair in children. And this is a relatively common condition and also a fairly simple question. We've used PICO format to try and frame it. So population, intervention, comparator, outcome, and time. And so for our Ninja study, this was children under 16, either nail plate discarded or replaced, and our primary outcome was wound infection rate. And this was at 2 weeks following surgery. So that was trying to build a research question within our network in the UK. And during that process, we had consensus meetings, a bit like this webinar, trying to engage surgeons from around the country. Now, in terms of starting to build a case once the research question's been set, then we found that the network's able to provide really good access to patients and the public to engage them early in trial design. It also allows you to build the evidence base for, and develop the protocol for a particular study. And again, Anita will talk about this in more detail with regards to the trigger. And as you know, with the trigger trial, we're starting with a clinician survey, and that's what we did with Ninja. Following on from that, we often need to do a service evaluation to find out what surgeons are actually doing. And the great thing is that all along this journey, there's output. So collaborators will get publications and presentations related to this. And this is just an example of a large number of collaborators on a letter actually to the Journal of Plastic and Reconstructive Surgery. We're hoping that also this will improve the quality of some of the studies. And you can see here in the same journal page, there's a retrospective single center cohort study, which is exactly what we're trying to counter. Certainly within the UK, the RSTN can also provide access to expert advice. I think going it alone in a single center without strong methodology support is tricky. And within the UK, we're certainly building expertise within the network so that people can share that expertise and really benefit from the power of having lots of people having gone through this process. So whether that's building the pilot study, perhaps accessing a research design service, of which we do have access to in the UK, engaging in established trial methodologists, and also doing the PPI work. Now, this will vary across Europe and the world, but certainly within our network, this is something that we can provide access to. Now, as we go along, this is just an example of a further publication related to the study, and this was the study protocol. In terms of funding as well, I think the network and developing a collaborative that crosses multiple units can probably improve the funding opportunities. By engaging network, you've got lots of people, lots of centers. It's going to be a most likely a bigger study with greater power and potential for impact, which is attractive to funders. From our experience, the early work, certainly most of the feasibility work, can be done for free or near enough free. And actually you can build up towards getting much more substantial grants to run a proper trial. The Ninja trial is going to cost around £350,000, which has been provided nationally. The RSTN, particularly in the UK, has really used free or very cheap pieces of software to deliver most of our studies to date. And these include research databases such as REDCap, for which you can get a license for free, and then common pieces of software such as Google, WhatsApp, MailChimp. These are all ways of engaging a network and keeping it running on a shoestring. So the total cost for us for this has been under 100 quid. Now, going back to this journey through the lowlands, where we climb the mountains to the peak, we have to be realistic. And I think surgeons in particular perhaps are slightly impatient. And through the network, we've tried to establish this journey so that people are realistic in terms of the timeline and what they can expect at different times. The Ninja study started in around 2014, and we're only just in the foothills now. about to embark on the final RCT. And this is the publication for the pilot study, which got us to the foothills, and now we're recruiting centres to the full definitive RCT. So finally, just to say that obviously within the network, it's a team sport. There are lots of people involved in every aspect of developing a network and maintaining it. And you'll find out more about the Trigger trial and the number of people that are involved in running it. It's big, but everyone gets to learn how to run the network, learn how to develop trials, and how to run them. So it's a very valuable experience. Thanks very much. A quick plug. The RSTN runs a scientific meeting each year, and this year it's in Edinburgh on the 21st, 22nd of June. More details on our website, and we'd be delighted if everyone from around Europe and beyond would like to attend. Thank you.
It's changing the way that people, and particularly trainees, are getting involved in research, I think, and what people are seeing as how research can be done. Obviously, not all research is going to be applicable to getting clinicians involved, you know, at an early stage, and I think sort of potentially igniting that flame with trainees particularly, and also getting big numbers for the studies that, let's face it, you need the big numbers. So I think at this stage we're going to move on to the Trigger trial. Anita, who I talked about from the Netherlands, a plastic surgery registrar there, is going to tell us about the Trigger trial.
Thanks, Richard. We're just arranging the Emmy is with me as well, so we have to arrange the sound. Is it okay for everybody? Okay, that's good. So I'm going to talk to you about the Trigger trial. Emmy told you, Emmy and I work together at the Jeroen Bosch Hospital in the Netherlands. And we both treated trigger fingers quite a lot. I always use the Kenalog 40 milligrams per milliliter. And when Emmy came, she told me she only used the A10 one. So up came the idea to have a research about it, to compare these two. So with this idea, I went to the RSTN and I met Matt. As you heard, Matt knows all about research and how to get from a simple idea to a whole landscape to climb a mountain. And what we did was looking at our question again. And Matt said, why should we only look to the corticosteroid in the dosage? Why shouldn't we look at the whole trigger finger concept? Is there evidence? So then we tried to get the Trigger trial going on, and we talked to Jeremy. You've met Jeremy in the video. He did the BEST guideline. And we discussed what would be the best question for a research like this. As Jeremy told you, there's a really high incidence of trigger fingers. I think we all treat hundreds of trigger fingers in our career. And we all know there are several treatments. There's absolutely no evidence for the conservative treatment with splinting or physiotherapy. There is some moderate evidence that steroid injections might be a good initial treatment, but as Jeremy told you, that evidence is quite poor. There is good evidence for surgery, but there are just 3 RCTs that compare surgery to steroid injections. And they all have shortcomings. So if somebody asks me, how do you treat the trigger finger? And that actually happens quite a lot because everybody knows I'm the trigger girl now. So I've got heaps of patients going to me, asking me, how will you treat my trigger finger? And I just have to tell them, I don't know. Of course, I'll tell them you can do splinting, you can do injections, you can do surgery, but we just don't know what the best option is. So as the time developed, Matt, Jeremy and I, we couldn't do it with 3 of us. So we've got the steering group now. It's actually Anglican Dutch, and we've got the supervising committee. And this is just the steering group. as Matt told you, we all need help. So I've got several collaborators. I've got collaborators for plastic surgery, collaborators for surgery, collaborators for orthopedics, for GPs. So it's quite a big group in the Netherlands already, and that's for each country that gets involved. So we keep spreading the word. Normally in research, at least what I've seen, when you've got an idea, you keep it for yourself, and you kind of keep it silent, and you work together in your own hospital to get your idea to a study and to get some result, and you publish it. And then you've got this really small numbers. And we did the opposite way. We just spread the word. We're gonna do research on management of trigger fingers. Who does want to get involved? And actually, everybody wants to get involved. As you see in the screen, it's not only the RSTN and the British Society, but it's also the Dutch Society for plastic surgery, for hand surgery, for rheumatology, for general surgery, and of course, ICOPLAST. So it keeps growing and growing, and I think that's very good. So back to the trigger trial. We developed a PICO. So for the randomized controlled trial we're going to do, the population is going to be adults, so everybody from up 18, which has one or more trigger fingers. The intervention is going to be surgical release. We're going to keep it pragmatic, so we'd like to have the technique that we think the surgeons should choose the technique to be used. So if you're used to doing open surgery, go ahead. If you're used to do percutaneous release, that's fine as well, as long as it's surgical. And we're going to compare that to the control group, and that's the steroid group. And in this case, it's going to be very pragmatic as well. As Amy told you, some hospitals in the Netherlands will only use A10, so they'll use A10. And some other hospitals will use the A40, and they just do the A40. Hinde told he's using lidocaine, use lidocaine compared to steroids, just what you're used to keep it pragmatic. And then for the outcome, the primary outcome will be the resolution of triggering. And secondary outcomes will be pain, hand function, that will be measured in a PROM, and of course, cost and complications. This study is going to be multi-center, international, multidisciplinary. So we're going to have a big group of patients, hopefully thousands and thousands. So that makes it possible to do subgroup analysis. So then we can go back to the different surgical releases that have been done, and we can compare the open surgery group to the percutaneous surgery group. And we can go back to the injection group and look at the A10 and the A40 group. And as Jeremy told you in his speak, we don't know lots about diabetes and rheumatoid patients. So I hope our group will be good enough so we can also compare diabetes to non-diabetes. We will do follow-up moments at 6 and 12 months. Matt told you we are running this whole landscape. So we start at the grass and we're going to the top. We're currently in the grass. Still looking how to get on. We've developed the Clinician Survey. I think every plastic surgery from the Netherlands has had the survey by now, and more than half of it completed it. And also in England, they're going on quite good. So we're pretty close to review our survey, claim some money somewhere, and then we can go ahead with a pilot RCT, and hopefully a guideline at the end. So what we did was we started with just an idea in an operating room in Den Bosch, and then all these different people came along, worked together, and hopefully at the end we'll finally have a guideline on how to treat a trigger finger. So the last thing I want to say is I really believe in this kind of research, and I think if you want to get to the top, and in my case I think a guideline for trigger fingers is the top, you have to work together, otherwise you can't reach the top. So if you want to get involved in the trigger trial, or you want some more information, just go to our website, send me an email, or find us on Twitter. So Richard, back to you.
Excellent. Thanks very much, Anita, for that rundown on what we envisage the trigger trial to be. So that sort of draws to a close our formal talks that we've got this evening. But what we're really planning on now is a bit more of a discussion, both about trigger fingers, but also about the trigger trial. We've just got one question which has come up, which I was going to put to the panel. So anybody who wants to answer it, but Julian van Rappard has asked, I believe that the success rate of steroid injection in trigger thumbs is lower compared to steroid injection in other digits. Do you share this opinion? And if so, were trigger thumbs included in all previous steroid injection studies?
I can answer this one. It depends on which article you will read. There are articles actually saying that steroid injection might work even better at the thumb. I know from the hospitals where I worked that they didn't like injecting thumbs, but it's not based on evidence. So it's worth to do some proper research about it.
Julian, you're unmuted, so you can discuss if you like.
Julian there still.
Or maybe not. There you are. Julian, you're unmuted.
Yeah. Is it working?
Yes, yes.
Oh, well. Well, thank you for answering my question. Yeah, I'm still a resident in plastic surgery, and I'm taught that indeed the success rate is lower in thumbs. So we are not used to inject steroids in the thumb, but I'm just curious about other opinions about other participants in this meeting.
Well, we could try. We could actually try a show of hands. I don't know if everyone can see the option of showing hands. Should I believe it at the bottom of the screen? But we could try that with the everybody who's there actually, and to see who does inject. Show your hand if you do inject trigger thumbs with a steroid.
Oh, 1, 2, 3, 4, 5, 6. 1, 2, 3. 1, 2, 3, 4, 5, 6, 7, 8, 9. 9 out of 37.
Okay. And any other views from the panelists on injecting trigger thumbs?
I inject trigger thumbs and steroid. I haven't noticed a difference, but again, I haven't looked hard enough. I agree that the data is probably not clear enough to demonstrate the difference between digits. You could argue, does the ring finger is better than the little finger or the index finger? I don't think we can answer that question based on the evidence we
have. In general, I tend to do an injection first, unless it's really severe. It's like a grade 4, as Emmy mentioned, and sometimes when there's a Dupuytren's, they can get really strict as well. So then I tend to go to surgery quicker, as well as with diabetics, but that might, not be backed up by the evidence.
Can I just ask the panelists as well, actually, has anyone tried use steroids in a grade 4 with success? Well, I tried it for starters and B, with any success. Professor Davies, yeah.
Yes, I think you lose nothing giving a steroid injection, because you're not going to be taking them to theatre with as quickly as you can give a steroid injection. And steroid injections, in my view, if they're going to work within about 5 days, usually. Yeah, no,
I suppose that's a slightly loaded question. I have done it in a couple of patients, and it has worked actually with, not always, but I agree. Similar lines to you, I suppose. It has had some benefit. So.
And do you wait, if it doesn't work and you have given the injection with steroids, do you wait until you operate a few weeks?
Well, the
yeah.
waiting lists in the UK mean you have to.
Yeah.
Oh.
I would, having a load of steroid underneath wouldn't bother me.
It's funny how you see after injection, when you do surgery.
I don't tend to inject grade 4s anymore.
I sometimes see it after injection when you open the A1 pulley that the tendon can be eroded. I also use A40. Maybe that's the reason why it's working actually, because it sort of etches away some of the tendon. But I've also seen from another specialty than plastic surgery an FPL rupture as a result of A40, or I'm not sure what they use, but injection of steroids. Is anybody also doing an A1 release percutaneously with a big needle? I hear about that.
It's not something I do, but don't know if any of the other panelists.
Yeah, I've had no experience of using percutaneous release.
Me neither.
Following percutaneous release.
Should we do a show of hands, Richard?
Yeah. Okay. So should we put it out to everyone, a group out there? Who, if you do percutaneous A1 pulley releases with a needle, do you want to show of hands again? We'll see what that comes. In the meantime, Abby, you were saying something there.
I can't remember what I was saying. No, I've never done a percutaneous release. I've seen some infections, and I've seen what I suppose is incomplete release. But again, patients that have come to me have not been done by experienced hand surgeons. They're usually done by inexperienced GPs or orthopedic surgeons. That's probably why I've seen those poor results. So that's not to say it's not a good technique. I think in the right hand, it's a great technique. It's just something that I don't do, and I'm not comfortable with.
Okay. So does anyone have any other questions or anything to comment about the actual technique of trigger before we move on to talking more about the trigger trial and the PICO outline, particularly for that? So just to move on then to, I mean, if we do have any other questions, then don't worry about it. There's, obviously put it in the queue and back to it. To move on particularly to the trigger trial, Rachel House has asked, in patients with multiple trigger fingers, will they be eligible for different arms of the trial with the different fingers? Anita, probably your best place to comment on that for everybody.
Yeah, I think for the trigger trial, if for all trigger fingers. If you're going to treat one finger with an operation, it's obviously going to affect the other finger as well. So that wouldn't work. So it's either surgery or injections for all fingers.
And again, I presume the technique for that, the incision for that, if specifically for multiple digits, will be pragmatic as well.
I have a question, because there's a few hand therapists that registered as well. Is there an optimal hand therapy protocol that you're aware of, or when would you treat trigger fingers conservatively without an injection, and when would you treat it conservatively after an injection, or is there no role for splinting after an injection? Question to the panel or the people that are listening.
So is that, sorry, Hinu, is that essentially where you're asking if the role of splinting after an injection?
Yes, or when do you use splinting as a single therapeutic option?
Can I just make a comment? Can you hear me? Can you see me? So let's make a comment firstly on the question of the multiple digits before we move on. There's a methodological problem with trying to include multiple digits in a trial. For Ninja, we have excluded multiple injured fingers. We will only follow up one finger into the trial, because it makes for the analysis quite complicated. That's on the multiple digit. And then for the splinting, I think the data would suggest that splinting is effective only if you catch the patient very early, and that's with a grade 1 within the first 6 months. Splinting can take quite a long time. It can be up to 6 to 12 weeks of splinting, and the patients do risk getting stiff during that time. I've only managed to treat one patient in my entire career successfully with splinting, and certainly in the NHS, by the time they come to my clinic, we've missed the boat on the opportunity for splinting.
Certainly, I think in the UK anyway, with the referral practices, you're right, Abby. It's by the time they come to us, they're definitely, in my experience anyway, they're certainly beyond that. Don't know what anyone else feels from that point of view. Prof. Davies, have you got any thoughts on that?
Of splinting at all. I mean, I have to say, and apologies to therapists, anyone who comes to see me, an injection takes 5 minutes, usually has worked within a few days. It would seem cruel to send them away without it.
So we've got another question here. Nick Jagodzinski asked, do others wait weeks or months between steroid injection and surgery to avoid infection? I think, Prof. Davies, you've partly answered that yourself. But otherwise, do people generally wait or for the steroid and then tend to get on fairly rapidly?
I think if you've given the patient a steroid injection, you're obliged to see if it's worked. So I think you wouldn't operate within, at least in my experience, within 6 weeks of the steroid injection to at least give it a chance to work. Because if you're going to operate, I know Tim's not going to like this, but if you've made the decision to operate, I think you should, and give a steroid, you should at least give the steroid a chance to work. There's no point giving a steroid and then operating on the next week. So I think a 6-week gap is fair, and I don't think that in my experience, there's significant increased risk of infection beyond the 6-week stage.
Can I come in and ask the panel, how many people think that a steroid injection which hasn't worked in 2 weeks is going to work in 6 weeks?
That's fine, Tim, but if you can get a patient to theatre within 2 weeks, then I would argue why you're giving a steroid injection. You've got to,
because they work.
Commit to a decision.
If we didn't believe they worked, you wouldn't be doing this study.
Well, we don't know. So if I commit to a steroid, I'm committing to that. We're going to run it. You're correct. If it hasn't worked in 2 weeks, it's not going to work in 6. But I won't operate on them just after 2 weeks. But if I think a steroid is not effective, then I would list directly for surgery, and I would not offer them a steroid in the clinic. The steroid does have a risk of complication, and it is painful. And the single injection for a steroid is as painful as a single injection for local anesthetic, which allows you to do the release.
Yeah, and how long did it take off work?
Correct. But then if you're going to, I agree what you're saying, but then we have to have that discussion with the patient. If they don't want to take time off work, then the operation is not the correct treatment for them, and then we will give them steroids. There's multiple different factors in the decision-making process.
Nick Jagodzinski should be possible to talk.
Hello.
Hi,
Can
Nick.
everyone hear me?
Hi.
Yeah, right, Nick.
Hey, Nick.
Yes, so I've been delaying. I normally don't operate on anyone if I've injected for a joint injection or a steroid for about 3 months, just because I thought that you got an increased infection rate. I completely agree that if you're giving a steroid, you should give it a chance to work. But just in terms of infection, I've been delaying for slightly longer than that. Maybe I shouldn't have been.
I think certainly I share Abby's view in that I tend to wait and see. If I'm giving a steroid, it's because I want to see if it works. So, and by virtue of the fact I'm going to struggle to get anyone back less than a couple of months, then that's normally how long it seems to take me. So, but it's obviously either worked or it hasn't by that stage. So.
And Richard, do you discharge them and wait for them to sort of make their own way back, or?
No, I generally see them, but I will say to them, cancel it if it's settled, then cancel it. But I feel I've intervened, and I feel I need to, ensure it's worked essentially and not lost in the system. I think there's probably a role for. I know some people have therapists sort of doing a telephone follow-up, and I think there's definitely a potential role for that. But again, it depends what service you have, and in the hospital.
So perhaps a trial in terms of follow-up, we might need to utilise some form of remote follow-up.
Certainly something that I think certainly something that would be interesting to look at and could be included. I think that leads us quite well. I mean, obviously the discussion that we're already having, does show that the trial has certainly a good and important question that can be answered. We're obviously going to be looking at, if we work through the PICO just as a bit of a framework, but the population, we're looking at adults particularly with, we've said, one or more fingers. Obviously from a statistical point of view, there needs to be thoughts on that. I know with the Ninja, we picked one finger, or are due to pick one finger. Does anyone have any sort of particular thoughts or comments on that?
I think from a methodological point of view, if you're going to follow it up, I think when you have multiple digits in the same hand, you complicate the data collection process, and you make it very hard to include that patient in the trial. So I think you can treat multiple digits, but only include one digit in the actual trial, if that makes sense. And that's purely an ease of analysis and interpretation later down the line from a trial point of view.
I have a question, if I may, to Anita and Matt. There's two perspectives of running a trial. One is as a participant, and one is as somebody running it. A question from the perspective of you guys running it: what can a society do to help these initiatives grow successfully? In the Netherlands, we got REDCap, an account for members of the Dutch Society for Plastic Surgery. But what would be your advice to society, to board members? And also a question to people that are involved in these trials: what is your experience, what they really need to include patients?
So yeah, Matt or Anita, you might be well placed to answer those.
Well, I think, to be honest, the barrier to entry is very low. So for trainees or consultants from around Europe, for instance, it's really just getting in touch with the Trigger team via the website, and off you go. The early phases of it don't need any ethical approval. So, for instance, the Clinician Survey can be answered by anyone, and we're very open to collaborators. I think from from a society point of view, that it's really raising the awareness of the benefits of multi-center collaboration, and really just providing sort of support in terms of advertising these sort of studies to members, and being very proactive in supporting and promoting them. Anita, I don't know whether you have any thoughts from a European, sort of mainland Europe point of view.
I think the system we are using with REDCap is very easy to get involved. I didn't have any experience with IT or so far, and I'm just programming REDCap like my iPhone. It's not very different, so I think everybody can get involved. You just have to spread the word. It's as easy as that. It's not complicated.
And one thing to mention, if you have trial ideas and you want to try and pitch them, then at the scientific meeting we hold every year in June, there's the opportunity to submit abstracts with trial ideas into our Viper's Nest, where we have a panel of experts who will ask questions and interrogate your trial idea. And the ones that have gone through in the recent past have then gone on to become multi-center studies. Not every single one will work, but I think opportunities like the Trials Day are great places just to bandy ideas around and try and build some consensus behind certain ideas.
Albie, have you got any thoughts on this, given your experience?
Yeah, so I think in plastic surgery in the UK 5 years ago, we were completely disjointed. We had virtually no trials or studies on our NIHR portfolios. In the last 5 years, the trainees and consultants in the UK have increased the number of clinical trials and studies on NIHR portfolio by 300%. That is significant. We now have a functional, recognized network around the UK that's collecting thousands of patients worth of data extremely rapidly. And that was unheard of. So I think collaboration, there's no boundary to it. It's only about attitude. And I think everyone who's involved today, it's fantastic. But I think our young surgeons are very collaborative. I will be honest with you, some of my senior colleagues are not. Is Tim still there? Tim has been fantastic. Tim Davis has been absolutely instrumental in encouraging multi-center clinical research in the UK. And so
I'll pay you later.
With us, but Tim has been absolutely central to the success, particularly in hand surgery, of UK clinical studies. So Tim's the chairman of the BSSH Research Committee, and he's guided and supported what we've been trying to do with the Royal College. So I think collaboration, especially with our young trainees, is extremely, extremely rewarding. And look, you know, we're all chatting together around Europe today, and I am sure that in 5 years' time, we will have answered this question, and we can all look back and say we were a part of that.
Been involved and been very much forefront of research in hand surgery, certainly over here in the UK. Can you hear me, Prof. Davies? Oh, I can't hear you now.
There are some questions on the chat as well, Richard.
Yeah, okay, so I'll come on to those in a second. I just wondered, Prof, I didn't know if you could hear me from the point of view of your experience of research in hand surgery.
It's hard work. I mean, you described, Matt described going from the meadows up to the Alps, to the peaks there. I mean, I think you first of all got to climb out of the swamp before you get to green grass. And that's very difficult when cardiology and other medicines have got an enormous track record for research, but that's because drugs are easier to study than surgery. And getting taken seriously has been very difficult. But now I think with the in England and Scotland, with the NIHR, National Institute of Health Research, it's far more open. It's the boom time to want to do research.
Yeah, definitely. It certainly seems like there's a much more focus on it as well in the world of surgery and plastic and hand surgery anyway, and obviously orthopedics seem to be ahead of us in the UK anyway. We've just had a couple of other questions coming up here on the chat. Miguel Johnson asked, what are your recurrence rates like, and do you think there may be a role for intraoperative injection at the time of release? Now, Rombu Molinar commented on this. I don't know, Matt, if you want to open up Rombu to see if he wants to comment.
Yeah, well, Miguel, you can talk, and Rombu, you can also talk if you unmute yourselves.
Okay, you hear me?
Yeah, absolutely. Go ahead.
Miguel or Rombu?
Yes. Okay. Well, I just mentioned I did that once, and it was the first and last time because I had a bad wound healing problem. And I think if you consider delaying operations after an injection, it would make no sense to do the injection during the operation.
Yeah, certainly not something that I've ever done. I tend to do one or the other.
That's right. Well, that's my point of view as well.
Hello?
Hello.
Just confirming it. Hello?
Hello,
is that Miguel?
Yes, this is Miguel. Right, I'm just extrapolating the information from the treatment. Are you hearing me?
Yep.
Right, so I'm extrapolating the information from like keloid surgeries where an intraoperative injection is given post excision of the keloid. And that somewhat prevents reformation of that fibrotic scar. So I'm just wondering if it makes sense. And I mean, surprisingly, we don't get that infection rate that you speak of with regards to at the time of injecting the keloid intra-op. So I'm just wondering if there's a rule for it.
Yeah, I mean, I think the pathological process of the two is quite different, isn't it? I agree. I think we do obviously use the intraoperative steroid when we do keloid excisions sometimes, and I agree. I haven't particularly had problems with that post-operatively, but I think it is a different beast, quite wide as I could tell. But I think certainly it's. I don't know what the other panel think. I think certainly the impression I get from our chat previously is that the people aren't, would probably prefer to wait a while after, at least a few weeks after a steroid injection, because of the potential risks. So, does anyone have any experience of injecting at the same time?
I think there's no option to start at the same time as surgery. I think the success rates of surgery are high in A1 pulley release. I think the skin is a different tissue. It's designed to fight infection. And so I think it's more resistant to steroid. I think the deep palm space is different, and your steroid is not really going into a specific tissue. It's just going around the tissue. And I think it's a different process. I don't think it's required because, again, if you look histologically at the pulley in trigger finger, there is no real inflammation. It doesn't really have the same inflammatory cell process that you'd think it would have. It's fibrocartilaginous dysplasia, which in fact, we don't actually know why the steroid works. It works, but we don't know why it works in trigger finger. So I think the process is different. I think there's no role to inject during the operation in trigger finger.
Great. And Prof. Davies, you've commented, obviously we're looking, the final follow-up in the trigger trial is at 12 months, but as you pointed out, there are patients who do recur or work for, up to 12 months or more, but then recur, which will be missed with this, which potentially will be missed with this. So, Anita, is that something that maybe you want to just comment on that and thoughts that have been put into that previously?
Yeah, we're still into designing the RCT, and we're looking at the best follow-up moments. In the Netherlands, it's quite common to see patients after an injection at about 6 or 8 weeks to know if it works, and if it doesn't work, you can go to surgery. But we have to set some point. And I think 12 months was a cutoff point to make it doable. But we will miss some recurrences, we know that. So just, if somebody thinks it should be 2 years or 3 years, please feel free to discuss, because we're still in a designing phase, and this webinar is pretty good to do some discussion.
I think designing a trial with a 3 will be hugely expensive with a large dropout in data collection at 3 years. I think Tim is making a point, but I think if most people have 12 months of problem-free following an injection, that is still a success to the patient, because I think most of us will agree that if you give them a steroid and they've been disease-free or problem-free for 12 months, that's quite a good outcome from the injection. I think surgery, you're expecting an almost, I see very few recurrence of trigger finger following an A1 pulley release. I think I've probably seen one, which was probably an incomplete release done by someone else elsewhere. So I think actually the long-term outcome data point will be judged by the patients when we do the PPI work. So the patients will tell us what they think is a good time point, and it may be even as short as 6 months. So I suspect around 12 months is probably going to be the cutoff. And we have to balance that with the cost of running a large international study. Now, talking of that, there's other cheaper ways of doing this. We don't have to do a randomized control trial. We can do a prospective cohort study across Europe. So there are other ways to get around that issue, and that could be a long-term prospective data collection, but it'd be very hard to run.
how do you go about, sometimes you have people who do a trigger finger release. I now use a transverse incision in the distal palmar crease. When I did a more Bruner-like incision, I would see sometimes people with a tender surgical area, no clear tendon adhesions, but just tender and stiff. How would you advise? Do you recognize this, and how do you deal with this? A question to the panel or people listening.
Does anyone want to take that on from the panel?
I've seen similar outcomes for both transverse and oblique incisions. They really can be tender. I haven't noticed a significant difference. I've only started doing more longitudinal oblique incisions in the last 2 or 3 years. I was always trained to do a transverse palmar crease incision. I don't see the benefit of that anymore. It's harder to do. And the patients, which I do a lot now, of just longitudinal oblique incisions, they all seem to have good outcomes. And when I see them at a year, usually for other reasons, another finger's triggering, the wounds have healed well. And that tenderness that you describe, yes, does occur in the early phase. I think down the line, most of that's settled, in my experience.
Mine too. Yep.
Mine too. I used to use the transverse incision as well, and now I use the Bruner-like incision because I don't see any difference post-operatively, but it's much easier to do the apollo.
Why I started using it after the complication that was Emmy mentioned, an infection. The hand swells up really badly, and if you have a transverse incision, the resting position is more in flexion, so the wound edges connect more easily. That's my theory, but I am very much aware that there's no evidence supporting this, but I like it now.
Okay, so we've got a couple of other questions come through. Rombu Molinar asked, does anyone see a minor extensor lag after dividing the A1 pulley? He sometimes does and tries to avoid this by instructing the patient to passively extend the PIP joint from post-op day 2. Does anyone see this, and is there no reason for the extensor lag? I must admit, it's not something that I've particularly noticed, I don't think, of our patients, although to be fair, I tend to see them at relatively, stage down, a few weeks down the line at least. So it's not something I've particularly noticed.
I've not particularly noticed, but I haven't particularly looked for it either, I have to say.
I think if your trigger finger is not causing triggering, but stiffness, whether it be loss of flexion or loss of extension, and they've been like that, so the finger's been moving, but not fully for quite a while, I do think that they take a while to gain, some of them take a while to gain full extension and sort of stretch out, and that's probably a secondary joint problem. And also some take a while to get full flexion back, even though the finger's done. And I was going to ask your definition of trigger finger. Is it a trigger finger which intermittently triggers, or are you dealing with stiff fingers as well, which won't either fully extend in your study or won't fully flex? Or those which feel stiff in the morning and just have really tender A1 pulleys, but never actually lose flexion or extension or trigger?
The question is all of the above. It's a pragmatic trial. The definition of trigger finger will be different between surgeons and between countries. And patients may feel I have lots of patients come to me going, Professor Jade, I have a trigger finger. They probably do. They're not always locking, certainly in clinic. Not all of them lock. I can't get them to lock, but their stories are of trigger finger, and they resolve with surgery or a steroid injection. I don't know. It's difficult. The definition is difficult. I agree.
And the other thing I was going to say is, maybe I'm a bit picky, and nobody's to take offence at any of this, that subgroup analyses, certainly the statisticians I speak to absolutely hate them. And if you think about it, diabetics aren't that uncommon with trigger fingers. And I think they would be particularly interesting. And rather than sort of recruit thousands to get your diabetics why could you not run parallel studies so that you don't have to correct 4,000 trigger fingers to get your 400 diabetics or whatever it is? And just, it seems to me that all studies, whatever analyses they do, past studies, the answer is always 400 or thereabouts. So why not just have recruit 400 of idiopathic, no obvious cause trigger fingers, and then run a parallel study at the same time of just diabetics. So when you've got your 400 idiopathic, you don't have to keep collecting them to collect the odd diabetic. You've got your diabetic one going on beside. Because I think that would be a very interesting group to look at, the diabetics.
I agree, Tim. I think that's an important group to look at, and I agree with you. Again, and as you know, methodologically running multi-arm studies with subgroups is complex, it's expensive, the statistics gets difficult. I think a lot of what we're trying to answer could be answered with a large prospective cohort study. And I don't think we even need a randomized control. A randomized control trial would be a good idea if a single country was doing it. But I think with the power of what we have here, the first stage should be a large, coordinated, prospective study. I think we'll find we answer the majority of the questions just by doing that, which should be relatively simple and relatively cheap, he says. I'm sure it won't be, but hopefully.
I would actually agree with all of that. I think a prospective study would work here, but I would make the follow-up longer and just till it peters out, because I think it's interesting to see how many people permanently avoid surgery or just defer it for a while, because it seems to me trigger fingers, people with trigger finger have, it's like a soft tissue. I always see it as a soft tissue arthritis. The steroid doesn't cure it, it just abates it. And they've still got the propensity, and that's why people get one trigger finger then another. I mean, that's armchair philosophy for me. And therefore, I don't think you're ever cured of it if you have a steroid injection. And it would be lovely to see the tail off. And I think that would be okay. May not be a burning question, but I think it would be very useful personally to see how many actually wear away and finally come to having surgery.
Would you do all rays at once if someone has trigger fingers and all rays?
Me, yes. And to be honest, I actually think this. I don't think injections for trigger finger. This is my personal view, and you can disagree. I don't think it's precision bombing. You don't have to get it dead in the A1 pulley. I think it's like dropping napalm, and if you drop it between two trigger fingers, both are likely to recover.
With you, Tim. That's exactly what my feeling is. If you look at the data would suggest you don't actually have to get it within the A1 pulley. I know we have all these fancy techniques, and I was taught by many consultants who are all experts apparently about how to get that steroid within that sheath without injecting the tendon. The risk of tendon rupture is actually very, very low. If you look at worldwide data, it is much less than we think. They were all scared that will cause it. I think just getting steroid in the rough region is probably all you need to do. And again, why does a steroid work? We don't even know why a steroid works. It just seems to do. And hence this issue with the different doses. Again, I'm not sure the doses make a difference or the volume you put in makes a difference. I'm not sure what the answer is.
I have to confess here, and you'll all be horrified, my dose of steroid is a vial. And I'm never quite sure what's in it.
I think you're right, Tim. I don't think it makes a difference. I use betnazole. Betnazole apparently has less palmar atrophy and it's more soluble. But again, the Kenalog 40 and 10, I will use whatever is on the shelf, because most of the times in the NHS, they don't have what I asked for. So I have to do what I'm given.
You don't see any difference?
Do you know, with a steroid, I assume it's not going to work. I know this sounds really bad. I assume it's not going to work. If I don't see them back in 6 months, they usually get points back. I have a lady today I've just seen. I've injected her every year for 3 years with a steroid. I just said to her, come on, let's just cut this A1 pulley now. She can't keep coming back. So I think Tim's right. The steroid just delays the inevitable. But that's, again,
then you have to,
why we're here.
Yeah, good. That's very good. It's good we've got, it's sparking some debate. We've got a couple of more questions, but actually I wondered whether Anne Dishma has commented. You're a hand therapist, Anne. I don't know if you're there, and you made an interesting comment on non-operative and non-steroid injection management of triggers by the looks of things. Just wondered about if you wanted to talk about that, Anne. Matt, have you? Can you unmute Anne? She's around. Are you there, Anne? Are you willing to share your experiences? Don't know if it's Anne that I can hear there or not. Sorry, Anne, I don't know if you're there or not. But oh, sorry, my mic doesn't work. Okay, so Anne said that she's a hand therapist and has treated patients with splints who are relieved from their locking fingers. Also gave them stretching exercises to stretch the A1 each hour, a 30-second stretch. Sometimes neoprene splints if the barrier is in the first part of the flexion trajectory, and also given advice about what movements to avoid. So it's a shame we can't hear Anne, because I think that would have been an interesting viewpoint on it, given that the rest of us are surgeons and quite happy to wield a scalpel by the sounds of things.
Make a comment on that. So I'm just throwing it out there. We know that patients are not compliant with splinting, and I will also suggest that they may not stretch their finger for 30 seconds every hour. I certainly wouldn't, because I will have other things to do. So I don't think we can really say that the splinting or the protocol influences the outcome. Again, I'm just being devil's advocate. I think if you look at many of the trials, they show that splinting is inferior to the majority of other treatment options. I'm not saying it doesn't have a role. I'm just saying it's more complex than we think.
Yeah, and I think certainly from certainly what Anne's saying is it implies that, doesn't it? It's more to it than just that. Evelyn has got a question. If a patient's involved in the trial with a finger and during follow-up another finger is triggering, what happens? Will they be excluded because outcomes are influenced, and will they be treated with the same intervention?
So that's interesting. So in the Ninja study, we have, it's slightly different. For Ninja, that's the nail bed trial, we are hoping that the chance of having a second digit injured in a child within the follow-up period of a few months would be highly unlikely. So we're hoping that that doesn't happen. Speaking to the statisticians, it does complicate the analysis. And their suggestion would be that that patient would then be withdrawn or excluded from the trial, or that's what they're suggesting. Now, I don't know how it would work for trigger, but we would have to raise that with the methodologists to see what they think would be the right way to proceed. And the other question, I don't know if we move on to the other question there, Richard.
Oh yeah, so Rachel Howes has asked, following on from deciding to only look at single-digit outcomes of patients with multiple trigger fingers, which finger would you choose? Will there be a hierarchy or the most severe trigger finger? And also, will patients be excluded if they have had a trigger finger treated prior to this trial starting?
So I think they probably would not be excluded if a different finger was treated prior to the trial, so that would not be included in the study. But it's a good question about which finger you would treat. You would probably select a single digit, and we may have to randomize that digit. I don't know how we do that, but that may be an option. Tim, you were going to say, in Dupotrons, what do you do in Dupotrons?
Yeah, we did this we had these dilemmas with Dupotrons, and in our feasibility study on that, we decided not to include patients who'd had previous treatment to other other fingers with Dupuytren's disease, as well as we didn't include recurrence. And we lost quite a few in recruitment terms. That was the biggest reason why we could, biggest reason for exclusion. We lost a fair few, I think about 20% of potentially eligible patients were excluded because of that criteria. And so we've been revisiting that in the definitive study. We would go on with that. But I don't think that's an issue with trigger finger because it's so common. And what we did for which finger, we asked the patient which finger annoyed them the most and chose that as the study finger. And I think you could do that with trigger finger as well. Say which is the most bothersome, which is, and you know, they'll probably select the one which jams the most, or they have to force straight. And they'll probably have a view as to which is the worst.
I think that's the way to do it. I agree.
Okay, so does anyone else have any other comments? We've kind of worked through, I think, in a roundabout way, the PICO format of the proposed the trigger trial. Does anyone else have any comments or any burning questions or things they want to talk about with trigger fingers at all?
Yes, sorry. Just some very basic questions. Do people use pressure bandages, and if so, for how long? Some people use double pressure bandages and then remove the outer pressure bandage. What are your thoughts and opinion on post-operative protocols?
Yeah, so does anyone want to comment on that, post-op protocols?
What we do in Nottingham as a group is we do the operation, they have a bulb, they have a little elastoplast bandage, or slightly bigger than elastoplast, sticky bandage over the wound, and then they have a soft band and crepe bandage on top, which applies a bit of pressure. And they're instructed to take that off at 2 days, and then use the hand as much as they want, but keep it dry. And at 1 week, take the little bandage off and do what they want. That's our management.
And ours is very similar. Sort of 2 or 3 days, take it off themselves and mobilise as pain allows, like our carpal tunnels.
We put a bandage on, and after 2 days they get it off themselves, but we don't use 2 different bandages. And I put some people do the, how do you call it, the pressure band. They put it off, do the hemostasis, and stitch it. And I usually keep it on, I do a bandage on, elevate the hand, and then relieve the pressure.
In terms of trial design, would we try to go for a fairly pragmatic approach in terms of post-operative dressings? I think for Ninja, we've been a little more prescriptive. But
I think for Ninja, one of the outcomes we were looking at was at first dressing change, because one of the criticisms of not putting the nail back on was that it causes more pain at the dressing change. That's why we had to be a little bit more prescriptive. I don't think pain at first dressing change will be an outcome measure for trigger. I personally don't think, this is my view, and I can't think of a reason, that the dressing would influence the outcome of a trigger release, I think, long term. I think, again, it depends on what our outcome measures are, which could include infection, which I agree could be influenced by the dressing. But I think in general, it may not, we should probably keep it pragmatic.
yeah, I mean, infection it certainly wouldn't be a primary outcome. It could be one of the secondary surgically related outcomes. But so I think the next step after the survey would be to do a prospective service evaluation or audit. And of course, all of that would come out in terms of how people manage the trigger fingers post-op. I don't think we're directly asking it in the survey. Is that right, Anita?
We are not asking about the bandage and the type of bandage in the survey, not yet.
No.
Can I ask, are you surveying a group of patients as well about what they feel about their treatment? I mean, I just going to, one of the reasons I asked that is I may have got it totally wrong, but your follow-up seems to be 6 and 12 months. Are you not doing any short-term follow-up to actually see how the patients are getting on when they're returning to work following their treatment, and when they can regain ability to grip and things like that in the early phase? Because the 2 stages, I mean, you'd have thought that it's either like needle fasciotomy or limited fasciectomy. The steroid injections likely to win in the short term, but they may not win in the long term. And I assume you're going to look at the short term as well as the long term in your study, or am I wrong?
I think the plan would be to have an earlier time point, but I think the primary outcome would probably be 12 months.
Yeah, that's fair enough. Yeah.
Or, well, yes, probably a slightly longer term. Maybe not necessarily 12, but it wouldn't be a very short follow-up outcome. But I think the 6 and 12 months was a very early banding around an idea in terms of follow-up timing, but they're likely to be a short follow-up. And that may be using some novel remote follow-up approaches as well, potentially. Because I'm not sure how often trigger fingers post-surgery come back to a dressing clinic. Certainly in my experience, they're often managed in the community. So.
Yeah, certainly in orthopedics, we give them an open appointment.
Yeah, yeah.
We've got a couple more questions that have come up here. One's about the trial. If patients, this is from Nick Jagodinsky. If patients have had an injection from the GP or had injections from the GP before we see them, can they still be added to the trial? What is the maximum number of injections people can give around each tendon? And I think they're both of those, I think, are related to the trial. Certainly the first one's related to the trial, actually. So we'll concentrate on that one first. Anita.
Yeah, if patients have been having an injection from the GP, we will probably exclude them because we don't know how the injection was given and what the effect will have been. So that's not a good starting point. So we'll probably exclude them from the study. And then from the number of injections, I think it's still discussable whether we're going to do a maximum of 2 or 3 injections. There are studies saying up to 5 injections is safe. But I feel it's going to be hard to motivate patients after a first injection failed to get a second one. Maybe you can get them as far as getting a second one, but how are you going to get them taking a 3rd or 4th injection? I think that's not workable. We should keep it pragmatic. So I think it's going to be a maximum of 2 injections. But we have to discuss that with the patients as well in the patient discussion group.
I think the answer to how many you can give is how often they need them. I mean, I wouldn't give injection after injection at 6-week interval because you're flogging a dead horse, and I would be worried about causing damage. But if somebody turns up every 6 to 9 months saying, I can feel it coming back, will you give me an injection? I will give them an injection because if they don't want time off work and things, it's their choice. And I'm quite happy giving a large number of injections at 9 months, a year intervals, and some people just need that. So within a year, well, I don't think I'd be happy giving more than 4. And I think most patients would throw in the towel after 2.
Yeah, certainly in my experience, they seem to get, as you say, Prof, if there's a long period in between them, then they quite like that. But if it's short amount of time, they just want it sorting generally. But they're all different, aren't they? I think when Ernst also asks about tourniquets, I know we've kind of covered this, but Matt, maybe we should do a quick show of hands for those who are still out there looking at, if you use a tourniquet, or maybe we should flip this round. Yeah, if you use a tourniquet for your trigger fingers, if you put a show of hands now, and see who uses them. Many people out there, Matt, showing us that they use tourniquets. Can't hear you, Matt. I don't know if you.
And how many
Sorry,
people
there
are
are
not?
six hands are showing. 6 out of 32.
And how many people are not using it then?
Oh, here we go again.
I started using a tourniquet when I started doing trigger fingers, but I actually stopped using it. I don't think it's very useful to use a tourniquet if you just do hemostasis as soon as it starts bleeding. You're fine, you can see it pretty good, and usually patients don't like the tourniquet. They say it's pretty painful. I don't use it anymore.
The tourniquet time in a trigger finger release is in the region of 2 to 3 minutes. Most patients do that quite well. If you were to I'm sure it will never happen, but if you were to accidentally injure one of the neurovascular bundles and you didn't use a tourniquet, do you think the patient has a legal stance against you to ask you why you didn't take that safety precaution? How would you answer them? Anita.
That's a good question, if they take me to court for that. Luckily, I've never hit a neurovascular bundle yet.
I know.
I hope to keep it like that.
Tourniquet is a...
But I really think you can see the neurovascular bundle if you don't use a tourniquet.
No, I agree with you.
So if I touched the neurovascular bundle, I would have touched it as well when I've used the tourniquet.
Okay,
I really don't see the use of a tourniquet anymore.
If you weren't using a tourniquet and you accidentally cut the nerve, just accidentally, and you then need to repair it, would it be advantageous to have a tourniquet in place? Though the problem, of course, is you prolong the operation rather than trying to repair a nerve without a tourniquet or trying to add a tourniquet while you're trying to fiddle around doing the nerve. I just devil's advocate, just trying to throw a cat among the pigeons for discussion.
But Anita, do you use adrenaline in your local, or is it so sort of? Yeah, okay. You're not doing it completely plain. Good.
The flip side of that, Matt, is when you use the adrenaline for both carpal tunnel and for trigger finger, the adrenaline effect wears off about an hour and a bit, and then you can get reactive bleeding, more bleeding that you don't see when you're diathermying because the vessels have gone into spasm, and then open up an hour later, which can cause more bleeding. So I know it's, again, just my technique. I will do it with a tourniquet, a minute or two for tourniquet time, release the tourniquet on table, stop the bleeding, put the stitches in, press, put the dressing on.
I tend to disagree with you on the story about more bleeding after using adrenaline. I don't think that has been shown, for instance, in a randomized trial of breast reduction surgery with and without adrenaline. This is one of the dogmas is following use of adrenaline, to my mind. But I do use tourniquet and I do use adrenaline, and it's a nice clean field. And like Abby's saying, it's maybe 3 to 5 minutes of tourniquet time. You can take it off. It's I don't see the reason why not to use it.
I think
well, there's going to be continued controversy, I'm sure, on that one. Has anyone heard of finger Spitzengefühl, apart from Anna? Have I said that the right way? Anna has come back. So finger Spitzengefühl apparently is the 30-second stretch. I presume that means that that's the 30-second stretch that's proven and shown at the FESH, apparently, so scientifically proven. So there you go. Apparently it's a Japanese woman who's the name that presented it. But that's as much as I can tell you. And unfortunately, Anne's microphone's broken. So, does anyone else have any other comments or questions for us? Oh, here we go. Nick Brinkman. I find the time of recovery after trigger release very variable in between patients. What could be the reason for this? Post-op hematoma query, adhesions query.
I agree with Nick. I think, Nick, it's not just trigger. I find it with every operation I do. Every patient has a different recovery time. I have carpal tunnel patients recovering within 5 days and others moaning at 3 months. I think it's multiple factors. I think it's the psychological aspects are significant. I don't think it's just as simple as a hematoma or adhesions. I think there's compounding synergistic factors, which patient psychology and our influence of that, how we prep our patients, what their expectations are, that all influence the speed of which they recover.
What's your protocol on using post-op hand rehabilitation hand therapists? Do you use it routinely or only for a certain number of rays, or what's your thoughts on that?
Are you asking someone in particular, Henny? Or throwing it out there to the
Just anybody.
Anybody.
Richard, do you want to go or shall I go?
Yeah, post-op, I mean, I personally, like you said, I'd tend to let the patients go, to be honest, and I do follow them up. And if they have a problem at that stage, then I'll see them, but I tend to let them go, and often they have a wound check at their local GP, to be honest, unless I suspect they're someone who's going to struggle. But the majority of patients, I don't routinely refer to therapists.
Can I throw in something about the surgery?
Yes.
Yes. We all say we release the A1 pulley. How do we, does everybody, absolutely, hand on heart everybody, you release what you think the A1 pulley is. Do you think, oh, I wonder if I've done enough? I mean, this is an orthopedic surgeon's take on it, and think I better release a bit more and probably go up into the A2 pulley, which I think can cause some orthopedic surgeons I know have caused bowstringing from being excessive. And in it, I just wondered in the study if there's going to be any guidance as to how much you should release, so that you don't have people just releasing half of the A1 pulley and people feeling they've got to go up into the A2 pulley for fear of recurrence. Do any other people like me wonder, have I released enough, and maybe speak a bit further?
I like the ones that trigger on the table preoperatively. So I ask them, show me how it's triggering, and you release it and you make them flex again and there's no triggering, then you know you've done enough.
Is that with a tourniquet on and local anesthesia?
Yes.
Well,
yes.
Yeah, that doesn't always work, I'm afraid to say, from my own experience.
But in my experience, it does seem to work, but I do a local anesthetics with adrenaline. I put the tourniquet on the upper arm, and I tell them to flex it, and I push it a bit further, and then they extend. And if they still have locking, I go further. Yeah, it usually works, but I tend to not to be too aggressive in my releases.
Are you a plastic surgeon?
Yes, I am.
That explains it.
So who visualizes the pulley when they release it, or who blindly puts a little pair of scissors and cuts it?
I used to do it blindly with this transverse incision, but now with the burner-like, I see it and I check it indeed, like Hina does. I ask the patient to flex and extend to see if it's locking or not.
I do a transverse and I see it, and then I cut it, and I usually see where A1 stops and A2 begins even.
I do an oblique incision now, Brunner, and I visualize it, and I'm pretty sure nowadays that I release just the A1 pulley, but I'm sure in my training I've done a little venting of the A2 pulley just to be on the safe side. I'm sure that happens routinely around Europe. And I'm sure there's no harm, Tim, to vent the A2 pulley a little bit. As we know, we can do up to 50% of the A2 pulley without much detriment to the hand.
I wonder if it sometimes causes weakness.
We'll blame the triggering on that, Tim. The underlying pathology, not the surgery.
That killed them of that.
As with some other surgical trials, we could always do a video demonstrating what we would, as a trial team, call an A1 release. And whilst people wouldn't necessarily have to directly follow it, it would be an example of which they can compare to.
Okay. I mean, we're coming at the webinar was due to last till 9, and it's coming up to 9. I think it's been a very informative. I never actually thought we'd get to 2 hours talking about trigger finger release, but we have done. So it's been great, and I think thank you very much indeed to all of the panelists, to all of you participants who've come along and joined us. It's been very good to hear everyone's views. Obviously, if you are keen to be involved in the trigger, then that'll be great to have you on board. I'm just going to put up hopefully if I can find it. This, hopefully you can see it now. The trigger trial email is below. If you're keen to get involved, got any further questions about the trial, about trigger fingers in general, please do contact us via this email. We want as many people as possible involved in the initial survey, and also interested in being involved in the future study. So I think just to sign up, it's been a very good experiment. I think it's worked very well. And thank you all very much indeed for joining us.
Can I just say, I don't think your diagram has any A1 pulleys.
Is that releases? That's why. That's terrible. Right.
Terrible.
Very good. Thanks very much indeed, everybody.
Thank you,
And
everyone.
get in touch if you'd like to.
Goodbye.
How do I get